not everyone who has metastatic triple-negative breast cancer to date has actually been able to get to a second line of therapy. And that is really a horrible statistic. We found that the combination of sacituzumab and pembrolizumab did much better than chemotherapy and pembrolizumab at keeping their cancer controlled for longer. So we saw a significant improvement in progression-free survival going from about 7.8 to 11.2 months. And so really, I think will become, I hope, a new standard of care treatment.
I have one of our favorite guests back with us, Dr. Sara Tolaney. Welcome back.
Oh, thank you so much for having me.
Dr. Tolaney, so today we're going to be diving into a fairly technical topic, but one that I believe that at least some of our metastatic breast cancer patients are going to be very excited about. We're going to be diving into the ASCENT-04 trial. I would love for you to talk to us about what is it, why is it important, and why is it going to matter for us as a society?
Those are big questions. So I will say maybe just to take a step back, when we think about treating metastatic triple-negative breast cancer, I think it's really critical that we think about making sure we're making the right treatment decision for our patients as that very first therapy that they're getting. And for a while now, we've had antibody-drug conjugates available for metastatic triple-negative disease, and the first one being sacituzumab govitecan, which had been approved several years ago. But it was for patients who had pre-treated metastatic triple-negative breast cancer. So in essence, it got approved for patients who were getting their second or later line treatment, and in fact showed that it kept cancer controlled almost 3 times as long as standard chemotherapy. It doubled survival. So it was a huge impact for patients compared to our standard treatments at the time. But I think our challenge is that not everyone who has metastatic triple-negative breast cancer to date has actually been able to get to a second line of therapy. And that is really a horrible statistic, right? It means that a lot of our patients who start first-line triple-negative therapy have such deterioration in health or die from their breast cancer that they can't even get to a second line of therapy. So it is so critical that we do much better for our patients with triple-negative breast cancer. We need to move our effective therapies into that upfront setting. And so we knew again that antibody-drug conjugates work great, but they were not tested in the first line. And so there's obviously been a lot of interest to see how we could best move these agents earlier. And so when we first treat patients with metastatic triple-negative disease, one of the things we need to know is, does the tumor have the PD-L1 receptor on it? This receptor is seen in somewhere between 25 to 40% of tumors in patients with metastatic triple-negative breast cancer. So it's not everyone. It's a little less than half of the patients who will have this receptor present. But we know having this receptor is a sign that your cancer is trying to evade the immune system. It's trying to hide and not let your immune system kill your cancer cell. And so in someone who has a PD-L1 positive tumor for a few years now, we've standardly used chemotherapy with a checkpoint inhibitor, so specifically pembrolizumab. And that combination of augmenting the immune response with chemo has improved survival outcomes for patients with metastatic triple-negative disease. So really important to know that your tumor has that receptor so you can get immunotherapy. But then we thought, well, if chemotherapy and immunotherapy is so effective, why not substitute that chemo with an antibody-drug conjugate? And we knew that antibody-drug conjugates were better than chemo head-to-head. And we also had some data to suggest there might be synergistic activity between the antibody-drug conjugate and immunotherapy. You could think that if you're killing the cancer cell so much better by giving an antibody-drug conjugate, you're going to release all these antigens that your immune system can then recognize as not belonging. And then these drugs can work together to kill the cancer cell even better than chemo immunotherapy. At least that was our hypothesis, right? And so that's a long way of saying we decided to do this trial called ASCENT-04, which looked at the combination of sacituzumab and pembrolizumab and compared it to chemo pembrolizumab in patients as their very first treatment for metastatic triple-negative disease if they had a PD-L1 positive tumor. And we found that the combination of sacituzumab and pembrolizumab did much better than chemotherapy and pembrolizumab at keeping their cancer controlled for longer. So we saw a significant improvement in progression-free survival going from about 7.8 to 11.2 months. And so really, I think will become, I hope, a new standard of care treatment.
Dr. Tolaney, I think I have like 30 questions.
Uh-oh.
But before we go too far out, can you remind our audience about what is an ADC?
Yeah, excellent question. So basically, I think of these ADCs as almost like a smart bomb. So basically, it's an antibody, and tagged to the antibody is a linker, and that linker is linked to chemotherapy. So on one antibody, sometimes you can have 8 different chemotherapy molecules. For example, sacituzumab has about an 8-to-1 ratio. So 8 chemos to 1 antibody. So you're able to deliver a ton of chemotherapy into a cancer cell. So in this case, the antibody is going to target a receptor that's on the cancer cell much more than that receptor is on normal cells, right? So it should be a receptor that is more specific to the cancer cell. So we know, for example, in triple negative breast cancers, more than 95% of tumors will have a TROP2 receptor on them. So that makes it a really good target because that's not commonly expressed on normal cells, but is almost always expressed on a triple negative breast cancer cell. So makes it a nice thing for that antibody to target. That antibody binds to the receptor on the cancer cell. It gets taken into the cancer cell and then releases all its chemotherapy into the cancer cell. So you're delivering a ton of chemo in a targeted way into the cancer cell. And so, again, I think people think of them as smart bombs because they're able to really target where the chemo needs to go and deliver a ton of chemo into it to kill the cancer cell more effectively. This is different than chemo, where you're just, giving a drug that kills cancer cells into the bloodstream. So it's not targetedly delivered into the cancer cell, right?
That's super helpful. Can you help us understand immunotherapy?
I can try. Um, basically, the way I think of it, I tend to be very simple in my understanding of these things, is that if I'm a cancer cell and I have a PD-L1 receptor on me, that receptor interacts with a T cell, so our immune cells, and interacts and tells it to turn off. So in essence, the PD-L1 receptor interacts with PD-1 on the T cell, and it's sending an off signal. And so that's telling the T cell, hey, don't do what you're supposed to be doing, which is looking for things that don't belong in your body and kill it, right? And so it's not letting it do its job. But if you block that PD-L1 receptor, so if you take an antibody that binds to PD-L1, no longer can the PD-L1 talk to the T cell, right? Because you've blocked that interaction. And so now it's not able to turn the T cell off. And so now that T cell should do his job, which is find foreign things that don't belong in your body and kill them, right? Such as cancer cells, which don't belong there either. And so it should be able to work. So these drugs like pembrolizumab actually inhibits PD-1. Atezolizumab is a drug that's an antibody binding to PD-L1. But in essence, they're just blocking that interaction between the T cell and the cancer cell so that the off signal is not being given. So people think of immune drugs as taking the brakes off the T cell and allowing the T cell to do its job.
I see. Okay, that is super helpful. So now coming back to ASCENT 4, I'm assuming, given what you've described for us, that for a patient to be kind of eligible for what was being studied in ASCENT 4, they would need to have cells that are expressing PD-L1. And as long as that's true, because 95% of all metastatic TNBC have TROP2, they could then get the ADC.
That's exactly right. So you're in a center where you were randomized, though. So half the people got standard chemotherapy with pembrolizumab and half got the sacituzumab with pembrolizumab. But that's exactly right, that everyone in the trial, actually, we did central testing. So everyone had to have their tumor sent to a central laboratory where we could confirm that the tumor was, in fact, PD-L1 positive. and then you would be able to enroll into the trial. We also centrally confirmed that they were triple negative as well.
Okay, super, super helpful. The next set of questions for me is, I've heard you say this a few times today, is we are able to control the cancer for some longer duration of time. And for what it's worth, Dr. Tolaney, in the last 4 or 5 episodes we've recorded, I've started hearing this language of control, control, control. So in the world of curable cancers and controllable cancers, can you help us understand what control means and how we actually study them? How do we define control?
Yeah, no, that's a good question. With metastatic breast cancer, unfortunately, we usually are not able to cure patients of their cancer. So we're not eradicating the cancer most of the time. I will say there are always rare exceptions to things. So I'll never say never, but in general, that isn't unfortunately the case right now. And so what we do see though is that we are able to either keep the cancer stable, meaning it's not growing and there are no new lesions that develop, or we're able to shrink the cancer and make it smaller. That's what I would consider control, is that the disease is either stable or shrinking. Whereas if there's a new lesion or growth in an existing lesion, we would call that disease progression, where it is not being controlled, meaning whatever drugs I've given it should not allow it to grow or make a new lesion, right? That means those drugs aren't working. And that's what we're trying to avoid.
So in Ascendo 4, it sounds like one of the endpoints was progression-free survival. And what that effectively means is we're able to control it for a longer duration of time.
That's right. So we're able to keep cancer from growing or developing new lesions for longer, meaning that patients had their cancer either shrinking or stable for longer when they got sacituzumab and pembrolizumab compared to the chemotherapy pembrolizumab. One unique thing that we didn't get into was that the people who got sacituzumab and pembrolizumab not only had a longer progression-free survival or longer time where their cancer was controlled, but they also had a longer duration of response. And what that means is that if you achieve a response, and the way we define that is having 30% or more shrinkage of your tumor lesions, that once, for those who did achieve a response, it lasted a lot longer in the sacituzumab pembrolizumab arm compared to people who got chemo and pembro and had a response. So even though the cancer was shrinking in both regimens, it was lasting much longer with sacituzumab pembrolizumab. And I think that was so, when I saw that, I thought, oh, that's the way, that's because of the immune response, right? Like we always think that when people have a response to immunotherapy, it causes a much longer duration of keeping things controlled. You can imagine, I guess the way I always like to think of this is that if your own body knows what's foreign and what's the cancer and can learn how to monitor for it and kill it on its own, that your T cells are able to do that, well, that's pretty good, right? Because then it means it will help keep things controlled longer. It becomes a lot more difficult to outsmart your immune system from resistance mechanisms. And so we've always thought that that allows, once you respond to immunotherapy, you can really hit a great response. I will say, I'm not sure I'm correct with my analysis, though, of Ascento 4, because interestingly, there was a sister trial called Ascent-03, just to confuse you, which was a trial that actually focused on the PD-L1 negative tumors. So those cancers that are the majority of patients who have metastatic triple negative breast cancer. And as their first treatment, they got randomized to sacituzumab by itself or chemo by itself and found that sacituzumab controlled cancer longer than chemotherapy. So that was progression-free survival was longer. But interestingly, duration of response was also much longer with sacituzumab compared to chemotherapy. So it wasn't, in this case, there was no immune drug being given, right? So my theory of saying the duration of response was so much longer in Ascento 4 compared for sacituzumab pembrolizumab compared to chemotherapy pembrolizumab in fact, may be driven by the sacituzumab by itself, right? That the drug on its own may be inducing its own immune response. These antibody-drug conjugates, we do think can function via immunogenic cell death as well. And so it could be more complex than I've made it. And so I think nonetheless, I think it's really exciting to see that these ADCs are working both in the PD-L1 positive and negative setting, and that they're not just improving progression-free survival, they're also keeping people having a deep response for much longer. And that I think is meaningful to patients because when your cancer shrinks a lot, you feel a lot better, right? You tend to have less symptoms from your cancer. And if you can keep that duration of response longer, that also hopefully means that people are feeling better for much longer, which I think is really nice to hear.
Very, very cool. So if I maybe let's switch to like looking out a little bit. So the trial was just done, data is about to come out, hopefully. What happens next in the world of trial? So the patients who are in the trial, we have at least some data from them. What happens next? Like how does a trial result come and actually affect patients in the real world?
Yeah, no, good question. So the data from ASCENT-04 was actually presented at ASCO last year. So that was June of 2025. And once data, in that data had literally, we had just gotten that data a few weeks before their presentation. So, I think much credit to Gilead who ran that trial, that they really did want to get the data out quickly because one, it's important to share that data fast and to then submit data to regulatory agencies for approval, right? Because, it takes time to do that process and to yield an approval. So hopefully in 2026, we hope to see that sacituzumab and pembrolizumab will become an approved regimen. Once it is, let's say, FDA approved, then it becomes standardly available to patients. In the US, there are also guidelines. And so the NCCN, for example, updates guidelines as new data comes out, sometimes even prior to approvals. And so we do see that the guidelines actually have been updated to include ADCs in that upfront setting, which I think is really nice to see. So, I think the general process is once data is available, if positive and looks like it will change standard of care, usually that data gets submitted to regulatory agencies for an approval. It does take several months to usually get an approval, but assuming that happens, then these drugs then become available and standard to administer.
Very cool. So now so hopefully 2026 sees the approval for ASCENT-04, so pembro plus sacituzumab. ASCENT-03?
And we're also hoping that ASCENT-03 will also yield an approval for sacituzumab alone in the people who are not eligible for immunotherapy as their first line of treatment for metastatic triple-negative disease.
So Dr. Tolaney, let's say the approvals come out. What happens? Like, what does a patient do? Can you walk us through standard of care today? Well, standard of care pre-ASCENT-04, ASCENT-03, standard of care post-ASCENT-04, ASCENT-03. If I'm a newly diagnosed metastatic patient, how do I know it's triple negative? How do I know if it's PD-L1? How should I be thinking about what happens?
Yeah, no, these are all excellent questions. So in general, once someone is diagnosed with metastatic breast cancer, meaning either they have a recurrence from a previous breast cancer that they had, or they have what we call de novo metastatic disease, meaning when the cancer presented in their breast at that time, the cancer was found to be spread to another place in their body. We usually like to biopsy that tumor wherever it may be. If someone has cancer in their liver, let's say, we would biopsy that liver lesion. We would test for estrogen receptor, progesterone receptor, and HER2. And if all three are negative, that would be what we would call a triple negative breast cancer. So that needs to be tested. We would also send the tumor to get tested for PD-L1. And, again, could come back either positive or negative. There's also other information we do like to know to make treatment decisions. One is we do like to understand if patients may have genetic predisposition to breast cancer. So it turns out it's important to know if someone has a germline BRCA mutation or a germline PALB2 mutation. These mutations can mean that drugs such as PARP inhibitors can be highly effective for triple negative breast cancer. And so we really like to have that information also upfront and to help us make a therapeutic decision. I truthfully also tend to send tumor for next generation sequencing, meaning I try to look to see if there are mutations within the cancer that may help at least inform future therapeutic decisions. Maybe not necessarily in the upfront setting, but can be informative longer term. So let's say I've done all my homework and I've tested the tumor and it's triple negative and it's PD-L1 positive. Um, then, in that setting, this used to be that the standard of care was to give chemotherapy. And by chemotherapy, it meant choice of either a taxane upfront, so nab-paclitaxel or paclitaxel in combination with pembrolizumab, or carboplatin plus gemcitabine with pembrolizumab. So physicians could choose which chemo they would give with the pembrolizumab. And we would make that decision often times based on whether or not they previously received chemotherapy and how long ago that chemo was administered. So if you had chemotherapy for your initial breast cancer and it then recurred, if it recurred super fast after that initial cancer, and you had prior taxane, it makes us think that giving you taxane again may not be the wisest decision because you just got it and the cancer came back. So maybe we choose carboplatin and gemcitabine. Whereas if your cancer had a long time between its initial presentation and recurrence, or maybe you've never had chemo before, then taxane-based therapy would make sense. So we kind of try to be logical about that choice. Whereas if you had a tumor that was PD-L1 negative, then immunotherapy would not make sense, and we would be giving chemotherapy by itself. So again, either a taxane or carboplatin gemcitabine. Or if you had a germline BRCA or PALB2 mutation, then you could instead be a candidate for a PARP inhibitor, which is just an oral pill. And so I think many of our patients would prefer getting that over IV chemotherapy. And we often will offer that to patients who have germline BRCA or PALB2 mutation. So again, that's why it's important to know that upfront as well. So I think that was kind of the algorithm that we would keep in our minds as the first line treatment approach. Nowadays, though, we've seen data emerge looking at antibody-drug conjugates in that upfront setting. And so I think the new paradigm will be that if you are PD-L1 positive, we would offer sacituzumab plus pembrolizumab. If you're PD-L1 negative, there's actually a choice of antibody-drug conjugates because, in fact, not just was there data from the CENTO-3 that looked at sacituzumab compared to chemotherapy, there was another trial called TROPAN-Breast-02 that looked at a different antibody-drug conjugate called datopotamab deruxtecan, or Dato-DXd. That study also compared Dato-DXd to chemotherapy in patients who are not candidates for immunotherapy and found that Dato-DXd also kept cancer controlled much longer than standard chemotherapy. And so we also anticipate an approval for Dato-DXd in the future as well. And so choice of Dato-DXd or sacituzumab for the PD-L1 negative patients, or consideration of a PARP inhibitor if you have a germline BRCA or PALB2 mutation. That upfront paradigm will now involve an ADC, at least as a backbone for first-line treatment.
Very, very cool. Dr. Tolaney, so if I'm a patient, we go through this whole roster. Depending on PD-L1 status, it's PD-L1 plus ADC or ADC alone in the first-line setting. Now it's control for longer, duration of response is longer, hopefully. What happens in second line?
You're trying to make this complicated, huh? So,
Lord, very first question. We move something from second line to first line.
Yeah, now what happens if you shift? So, in essence, if you got chemotherapy, if you got an antibody-drug conjugate in the upfront setting, then what we would give second line depends a little bit in truth. So it would be chemotherapy for most. So single agent chemotherapy would generally be what we would give. However, if you do have a tumor that is HER2 low, So meaning it has a little bit of that HER2 protein, but is not a HER2 positive protein level, then you could get a drug called trastuzumab deruxtecan or TDXD that is approved as a second-line treatment approach. Or if you have not seen a PARP inhibitor and you have a germline BRCA or PALB2 mutation, then you could get a PARP inhibitor as second line. So it's usually choosing between getting chemo or TDXD or PARP, depending on germline mutation status and HER2 status. So I think we need a little bit of information, but you do have choices as that second line approach.
I'm assuming this is partly why you're also, for yourself, doing next generation sequencing, because there's the somatic mutation universe as
Yes.
well. Presumably, that
Yeah, so you got it. You're exactly right. I didn't get into the nuances of that, but you're totally true. So the reason I do like getting that tumor sequence is in part for exactly what you said, is that it turns out there is data that patients who have somatic BRCA mutations also respond to PARP inhibitors. So meaning if the BRCA mutation is found in your tumor, but not something that was inherited, you still seem to benefit from a PARP inhibitor. So it's really nice to know that, because it could mean you're a candidate for a PARP inhibitor. So you want to get that sequencing done. It also turns out there's some other findings that may influence therapy. So, for example, if you have a very high tumor mutation burden, so a TMB that's 10 or higher, we could consider immunotherapy for you. So even though maybe your tumor is PD-L1 negative, and we would say maybe you're not a candidate for a checkpoint inhibitor. In fact, if your TMB is 10 or higher, there's data to suggest you may respond to a checkpoint inhibitor. So that gives you potential option for immunotherapy. And then there's some mutations that are more rare, that we are always looking to see, if someone may have NTRK fusion, MSI high, things that are super duper rare. But again, it's important to make sure that patients are candidates for other targeted approaches. And, truthfully, being at an academic center, I'm also always looking to see if people are candidates for clinical trials. And so sometimes having particular genomic alterations, there are targeted drugs that are investigational being studied in trials that could make you a candidate for a specific study. So I always want to know that for my patients as well.
I think the nerd in me is very happy right now because I think my head is up. I think I remember from our last episode, which I want to say is almost a year ago. I think I remember you saying some version of, for this was for early stage, not metastatic, but early stage TNBC patients, the practice paradigm is shifting closer and closer to the HER2 or hormone positive with neoadjuvant options, surgery, and then adjuvant options. If you were to come up with an analogy of what we're seeing with mTNBC, it feels like a fairly radical is probably not the right word, but it feels at least like now patients with metastatic TNBC have far more options than they did
Yeah,
earlier.
I will just say I think it's a tremendous shift because, I'm getting old, but, I've seen such an evolution in my time as a breast oncologist, because when I was in training, all we really had was chemotherapy for triple negative breast cancer. There were no targeted approaches. There were no antibody-drug conjugates. We didn't have PARP inhibitors. We didn't have sacituzumab. We didn't have Dato-DXd. We didn't have immunotherapy. Again, I'm dating myself, but we didn't have TDXD. None of this stuff existed for triple negative breast cancer, and it was hard. And now we see patients doing so much better, living so much longer. And we didn't get into this, but the number of new agents that are moving into this field is a a very high number. And there are so many clinical trials, novel antibody drug conjugates, novel targeted agents. So, I think there's so much hope for triple negative breast cancer in general. Their novel immunotherapy agents, bispecific antibodies. It's a rapidly evolving space. And I will just say it's so nice to see the evolution again, coming from my fellowship days to now maybe 20 years later. To see such a change in outcomes is tremendous.
Dr. Tolaney, if you had to give, this is probably my last question, if you had to give advice to a patient today who is in the middle of getting diagnosed, metastatic, triple negative, the data comes out slowly on your diagnosis itself, what would you tell that patient?
No, obviously, it's a hard diagnosis to be given, and it's a hard time to go through that process. But I do want people to realize there are a lot of treatment choices, and it is continuously evolving. Literally, what I told someone a year ago is no longer true, right? That everything is evolving so quickly. And I do think it's really important, particularly in triple negative breast cancer, to understand all your treatment choices and to make sure you understand what clinical trials are available because the space is changing so fast. There's so many new drugs that are moving into the space, but your choices will be even larger if you get involved in clinical trials. And so please make sure that you're seeing someone that has access to novel therapies because, again, they can work so well, and you want to make sure that your menu of choices is long so that we can really have all options available to you.
Dr. Tolaney, thank you so much for being a guest on our show. I know from the community that you are a fan favorite.
Oh,
I have
very
enjoyed-
sweet of you. But again, I really enjoy doing this. So thank you for the opportunity. It's always so nice to chat with you.
Thank you, Dr. Tolaney.
Thank you.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The opinions of the speakers are their own and do not represent the opinions of organizations they're affiliated with, nor do they reflect the opinions of Mantacares Inc. or Mantacares' sponsors.